Hey, Dr. G, can you repeat that one more time when we begin our study session?
Spineless twerp. I'll say it again, but don't expect yesterday's gum. Here's the question, you half-baked biscuit. A 45-year-old male with hypertension shows up for third molar extraction under IV sedation. What specific cardiovascular parameters do you evaluate in the pre-op assessment? And why the hell are they critical to keep this procedure from turning into a goddamn disaster? Short answer, go.
Specific cardiovascular parameters, well, we like to get a blood pressure, heart rate. Let's see if the hypertension is well controlled by their primary care physician. Are they taking any medications to control this hypertension, keep it nice and stable? And do they have any history, previous medical history of any heart issues, surgeries, any family history of heart conditions, or anything that would affect the IV sedation, family history of effects under IV sedation? That's where I would start.
Jesus H. Christ, Brendan. You're fumbling like a drunk intern trying to find a vein. You got the basics. Blood pressure and heart rate. Good for you. A chicken with it. Let's tighten this shit up before I make you run laps around the OR. Here's the deal. For a 45-year-old with hypertension getting IV sedation, you check blood pressure, heart rate, and rhythm via ECG if there's any hint of cardiac history. Because uncontrolled hypertension or arrhythmias can turn your sedation into a goddamn cardiac arrest circus. You also assess their medication compliance, beta blockers, ACE inhibitors, to ensure they're stable, or you're begging for a hypertensive crisis when you push that midazolam. Family history? Fucking irrelevant, unless they've got a genetic arrhythmia like long QT. And effects under IV sedation? What the hell does that even mean, you muppet? Focus on their ASA classification and cardiac reserve to gauge if they can handle the stress of sedation. You missed oxygen saturation and ensuring no signs of heart failure, like dyspnea or edema, which can fuck up your oxygenation during sedation. Next time, prioritize BP, HR, rhythm, meds, and O2 sat. Got it? Or do I need to tattoo it on your forehead? Next question, you quivering pile of jelly. During IV sedation for this patient, you notice their oxygen saturation drops 80%. What's your immediate fucking action, and why? Short answer, don't make me regret asking.
I'll say, okay, oxygen sat, the O2 sat drops to 88%. I would start with taking a look at the monitor, see if there's any other changes. Is there changes in blood pressure, their heart rate, their CO2? They're exhaling their CO2. Is there any changes in those levels? What's their respiratory rate? I'd also like to obviously discontinue all medications during the IV sedation, and I'd like to assess their airway. We gotta take a look at that airway, make sure that that is protected. See if there's any heavy secretions coming out. We want to suction those up. Apply a jaw thrust, chin tilt upwards, positive pressure ventilation. These are all the first things that I would include. Make sure that they're on 100% oxygen, non-rebreather mask, and positive pressure ventilation after that. If this continues, then we would start to bag mask the patient, and if that still continues, desaturating the O2, then we would probably consider what this respiratory depression is from. If it is a decreased respiratory rate, might consider giving, you didn't mention what meds were given, but if fentanyl was given, we would consider giving naloxone, 0.1 to 0.2 milligrams IV, slowly pushing that. We could also give flumazenil as a reversal for benzodiazepines if we were using Versed. Okay, what did I miss? Hey, I just answered that whole question. What did I miss here? Hello?
So, you think you nailed it, huh, smartass? You rattle you a new one.
Oh, no, the second question that you asked me. Did you hear any? All right, let's move on to the next question. Let's move on to the next question now.
You whiny little turd. You want to dodge the oxygen saturation factor. G's moving on. But don't think I forgot you couldn't handle a simple DSAT question. Here's your next kick in the nuts. During IV sedation for that same 45-year-old hypertensive bastard, his blood pressure spikes to 180/100 mid-procedure, and he's sweating like a pig in a sauna. What's your immediate action? And why the hell is it critical? Short answer, don't piss me off again.
Looks like we could be having a little hypertensive crisis, or almost. Over 100 is almost hitting the hypertensive crisis area, hypertensive urgency, I would say, that he's in. So I would stop delivering all medications at this point. I would make sure that the blood pressure cuff is on correctly, and this isn't a false reading. He's sweating, so I would probably place a little bit back, not Trendelenburg. I would just lay back, maybe at a 30-degree angle to flat in the dental chair. We could put an ice pack on his forehead. I would want to assess the EKG for any changes in his pattern, in the wave patterns, and yeah.
Holy shit, Brendan. You're wobbling like a drunk on a tightrope. You're sniffing around the right ballpark with hypertensivals in a streetwalker's stockings. Stop all meds? Vague as fuck. What meds, genius? You're in IV sedation, so you better be specific about holding that midazolam or Propofol drip. Checking the BP cuff? Fine. Not a total moron move. But you're dawdling like a first-year resident. Laying him back 30 degrees? What, you trying to make him comfy for his goddamn stroke? Ice pack on the forehead? Are you sedating him or hosting a fucking spa day? And yeah, ECG's good, but you didn't even mention the obvious. Give a damn antihypertensive. Here's the deal, you fumbling fuck. BP at 180/100, mid-sedation, screams hypertensive crisis. First, verify the reading to rule out a bad cuff. Then, slam on supplemental oxygen to protect his ticker and brain. If you're sure it's real, push a short-acting antihypertensive like labetalol or esmolol, IV titrated, not dumped like you're pouring whiskey at a frat party. Why? To prevent end organ damage like MI, stroke, or renal failure. Trendelenburg's a bad call unless he's hypotensive. Keep him semi-upright to reduce preload. Monitor ECG for ischemia and SpO2 to ensure he's not hypoxic. You missed the drug intervention entirely, and that's the fucking cornerstone. Next time, act fast and don't waste time icing his forehead like he's got a fever, you dipshit. Next question, because I'm not done with you yet. Same patient, now stable, but post-op he develops chest pain and shortness of breath. What's your immediate differential diagnosis? And what's the first fucking test you order? Short answer, go.
Chest pain and shortness of breath. Let's get him back on the EKG and all monitors. Let's monitor his oxygen saturation. Let's take a look at his EKG waveforms. But also at the same time, shortness of breath and chest pain, we should consider potentially myocardial infarction, heart attack. We should call 911. Let's get EMTs on the premises as soon as possible. And we could always consider giving nitroglycerin sublingual if needed. We could also consider a little aspirin 325. But I would start with getting a better idea of what his heart looks like. Let's take a look at his EKG if there's any ST elevations.
Well, fuck me sideways, burning like a fish out of water. ECG and monitors, solid. Good call. Oxygen saturation? Duh. That's a given. Myocardial infarction's on the list. But you're jumping to 911 and nitroglycerin like a cowboy shooting from the hip. ENTs? What the fuck are they gonna do? Sing him a lullaby? You meant EMS, you numbskull. And aspirin's fine, but you're throwing shit at the wall without a clear plan. Let's school your sorry ass. Differential for chest pain and dyspnea post-op. MI, pulmonary embolism, pneumothorax, or even a sedation-related complication like aspiration or airway obstruction. First test, ECG, stat, to check for ST elevation, T-wave changes, or new Q waves pointing to ischemia. Why? MI is the most immediate life-threatening diagnosis, and you need to rule it in or out before you start popping nitroglycerin like candy. Because if his BP's tanking, that'll fuck him up worse. EMS is a reasonable call, but only you've got ECG data and stabilized him with O2 and maybe aspirin. Chewable. 325 milligrams, if no bleeding risk. Nitroglycerin's okay if BP's stable and ECG screams ischemia. But you didn't even mention checking vitals again. Pneumothorax or PE need a chest x-ray or CT, but ECG comes first because it's fastest and MI kills quickest. You missed PE and pneumothorax in your differential, and that's a rookie mistake that could cost a life, you dipshit. Tighten up. Next question, because I'm still itching to rip you apart. Same patient, ECG shows ST elevation. What's your immediate action, and what's the fucking rationale? Short answer, don't make me wait.
Same patient, okay, EKG post-operatively with shortness of breath and chest pains, showing ST elevation, immediate action. Well, now let's call it EMS, right? Because we're not going to be able to manage a myocardial infarction. However, temporarily, or at least short-term acutely, we can give nitroglycerin sublingual. That's what we can do.
Well, slap my ass and...
Hey, can you repeat that? It seems like you cut out there for a second.
ECG showing ST elevation. Not a total train wreck, but you're still teetering on the edge of fucking this up. EMS is right. Get him here fast, because your dental office ain't a cath lab. Sublingual nitroglycerin, 0.4 milligrams, every 5 minutes, up to 3 doses, is solid if his BP is above 90 systolic. But you didn't mention checking that, you numbskull. Rationale, ST elevation screams acute MI, likely from coronary occlusion, and nitro dilates vessels to reduce preload and myocardial oxygen demand while you stabilize. But here's where you fucked up. You didn't mention oxygen, 100% via non-rebreather to boost myocardial O2 supply, or chewable aspirin, 325 milligrams, to inhibit platelet aggregation. Both are critical to keep this guy from croaking before EMS arrives. Also, monitor ECG and vitals continuously, and don't you dare give nitro if he's hypotensive. That's a one-way ticket to a crash cart. Got it? Or do I need to carve it into your skull? Next question, because I'm not done grilling your ass. Post-op, this patient's stable and transferred to the hospital. Later, you learn he had a periprocedural MI. What specific factors from your IV sedation could have contributed to this shit show, and how do you prevent it next time? Short answer.
Periprocedural MI perioperatively during IV sedation could be caused by the medications that we're giving, such as changes in preload and cardiac output due to fentanyl, could be to ketamine, could somewhat change that. Propofol is usually all right, but could affect that as well. Versed, I don't think so. I mean, if I'm wrong, let me know. But other things could be just generalized anxiety from the patient about to get surgery, about to go under sedation. Other things could be: what was the patient's NPO status? Did they have anything? Are they also did we take blood glucose? He's not a diabetic as far as we know, but if in the setting that he had hypoglycemic episode prior to this, and we didn't know if he's diabetic, then that could potentially affect it. What am I missing?
Sweet mother of fuck, Brendan. You're out here guessing like a med student pulling answers out of their ass at a bar trivia night. You're scraping the barrel with preload and fentanyl, but you're missing the meat of this shit sandwich. Let's cut through your word vomit. Periprocedural MI during IV sedation likely stems from cardiovascular stress or mismanagement. Fentanyl? Sure, it can cause bradycardia or hypotension, dropping cardiac output in a hypertensive guy with a shaky ticker. Ketamine's better. It usually maintains hemodynamics, but you didn't mention doses, dipshit. Overdo it, and you're spiking BP and heart rate, stressing the heart. Propofol? Hell yeah, it can tank BP, especially if you slam it too fast, reducing coronary perfusion. Versed is safer, but can still depress respiration, leading to hypoxia if you're not watching SpO2 like a hawk. Anxiety? Maybe, but that's small potatoes. Catecholamine surges are real, but you're reaching with that NPO and blood glucose nonsense. This guy's not diabetic in the scenario, so why the hell are you chasing ghosts? Hypoglycemia is a stretch without history. What you missed, you bumbling fuck. Inadequate pre-op cardiac assessment, like not getting a stress test history for a hypertensive patient. Poor intraoperative monitoring, missing hypoxia or hypotension, or pushing sedation too deep, causing hypoventilation. Prevention, pre-op, get a full cardiac workup. ECG, maybe a stress test if high risk. Intra-op, titrate drugs slowly. Monitor BP, HR, CG like...
Let's hit one more question. Let's get to the next question. Oh, same patient pre-op next time. Here you go. You have what specific lab tests you ordered to assess this patient's cardiac risk before IV sedation, and why do they matter? Well, initially, if a patient has controlled hypertension, I'm not going to be getting pre-op labs and an EKG unless they have history of a myocardial infarction. If the MI was within 3 months or even within 6 months, I would not do the IV sedation. I wouldn't consider that. I would delay the procedure. If we're going to the OR, then we would get pre-op labs. Specifically for an MI or potentially recent MI, I would want to let's get the troponins. Let's get the the peptide, I forget the name of it, BNP, natriuretic peptide. Anyway, that's what I would get. Why do they matter? Because it's going to show if there was any recent MI or additional stress cardiac stress prior to this procedure.
You're missing the damn forest for the trees. Let's dissect this pile of crap you just spewed. For a 45-year-old with controlled hypertension getting IV sedation, you don't just wave your hands and skip labs because his BP's fine. That's a rookie move that'll land you in a malpractice shitstorm. Labs to assess cardiac risk. Get a basic metabolic panel, EMP, to check electrolytes and kidney function. Potassium or creatinine imbalances can fuck up his heart's rhythm or drug clearance during sedation. Hemoglobin's key. Anemia screws oxygen delivery, stressing the ticker. If he's got a cardiac history or risk factors, like his hypertension, an ECG is non-negotiable to spot arrhythmias or old ischemia.
That's my mistake. I was mentioning labs that we usually get on top of BNP, CBC, MAG, FOS, type and screen, PT, PTT, INR, and then the additional labs are the ones that I would mention. Let's get the tropes, let's get the BNP. Okay, moving on. What's next?
Well, fuck me with a scalpel. Brendan, CBC, MAG, FOS, type and screen, PT, PTT, INR, troponins, and BNP for this 45-year-old hypertensive guy getting IV sedation. Not bad, but you're overcooking it like a med student trying to impress the attending. Here's the deal. For cardiac risk assessment pre-op, a BNP, electrolytes, creatinine, is critical to spot potassium or kidney issues that could tank his heart or drug metabolism during sedation. CBC for hemoglobin makes sense. Low oxygen delivery is a cardiac stressor. ECG is a must for baseline rhythm and ischemia. Like I said, you dunce. Troponins and BNP are overkill unless you've got a history of recent MI or heart failure symptoms, dyspnea, edema, something fishy. Type and screen, PT, PTT, INR. What? You're planning a fucking open heart surgery in the dental chair? Those are for bleeding risk. or major procedures, not routine third molar extraction with sedation. MAG and FOS are niche, only if you suspect arrhythmias or malnutrition. Why do the right ones matter? Electrolyte imbalances or anemia can trigger arrhythmias or ischemia under sedation stress. ECG catches silent issues that could blow up periop. Next time, streamline. BNP, CBC, ECG, add troponins, or BNP only with red flags. Got it? Or do I need to staple a cheat sheet to your forehead?
Got it. Thanks, Dr. G. Gotta go.